Hello, my name is Aram Salzman, um, and I'm here to talk about our cancer risk assessment for personalized screening and prevention of cancer. Our tool was developed at Massachusetts General Hospital here in Massachusetts, and our company founder is Kevin Hughes, MD, who is co-founder of the company, co-director of the Avon Comprehensive Breast Center at Massachusetts General Hospital. Over many years, he developed this tool with Brian Drowan, PhD, co-founder of the company and chief technical officer. We're the leader in cancer risk assessment. Our mission is to identify high-risk patients for screening and prevention to improve patient care and outcomes. The original version of this software was built in 2006 as a guidelines-based breast cancer risk assessment tool. The first site to go live was Newton Wellesley Hospital here in the greater Boston area, and 70 facilities are live on this system today. We are also the integrated risk engine for the Epic EHR. In February of 2015, Epic asked us if we could incorporate our risk engine into the Epic electronic health record and the Epic Radiant Radiology Information System module. The company was spun out as a private company in March of 2014. In the women's imaging universe, there are established guidelines for patients receiving supplemental MRI screening over and above their mammography. And yet, 99% of eligible women do not get screening MRI today. And interestingly enough, of the MRIs ordered, many of them do not meet guidelines. So there are many women today who are not meeting recommended guidelines for MRI screening, specifically the American Cancer Society recommendation that women with a greater than 20% lifetime risk of cancer receive breast MRI over and above their mammogram. Our medical advisory board includes Kevin, who I mentioned earlier, David Oyhus, currently at Johns Hopkins, who is one of the other real gurus in cancer risk assessment. Dan Kopans in the imaging universe is really one of the most important technologists in the field, developing many of the key technologies in women's imaging, including the original breast tomosynthesis technologies, breast ultrasound imaging technologies, and breast MRI modalities. Last but certainly not least, Giovanni Parmigiani is the primary developer of the BRCA Pro model, also at Harvard. He advises us on cancer risk modeling overall. Just to touch briefly on national policy issues, the Affordable Care Act, Meaningful Use, Phase 2 and Phase 3, says that we should look at family history when considering patient care. Now, for most disease states, I'm not even sure what that means. And yet in women's health, and specifically breast cancer, the correlation between family history and patient care is very strong. The challenge is that it's very difficult to actually do anything with that information. So given how challenging it is to run the risk models, to look at guidelines, doctors follow those guidelines very sporadically. We develop risk assessment tools that help deliver guideline-appropriate care with a focus on return on investment. How does this all work? So patients can enter their own family history and risk factors, whether that's on an iPad or other tablet computer in an imaging center or at home via internet. Once the patient enters those family history and risk factors into our system, risk calculations are performed automatically using the accepted models, and recommendations based both on established guidelines and your own institution-specific care practices happen automatically based on the patient's risk profile. The goal of all of this is for high-risk patients to receive appropriate care, whether that's MRI screening or potentially genetic testing, or even for very high-risk patients. Some of our clients have set up in their systems that the system will trigger recommendations for prophylactic therapies, i.e. tamoxifen, or even consideration of prophylactic surgeries for very high-risk patients. Just a little bit of additional context. Over many years, our client base has the experience that if a hospital or imaging center is running all of the accepted models, roughly 15% of the mammography patient population will be flagged as high risk. So every for every 1,000 mammograms performed, we're going to be identifying 150 patients who might benefit from breast MRI. To take a little bit of a look at the larger scene nationally, I find this Wernley study rather interesting. In the Wernley study, they looked at nearly 300,000 women who received screening mammograms. In that population, in this very large study, just under 9,000 women received a breast MRI. So 0.4% in this very large study of women received a supplemental breast MRI screening, and yet we know 15% of that population is at elevated risk. We are massively under-identifying high-risk women in the United States. The last piece of that study, which was even more interesting, that of the women who received the MRIs, 75% did not meet guidelines for MRI screening. So not only are we not identifying high-risk women, the women who we are giving MRIs to are potentially not the correct women. It is challenging without a dedicated tool to identify high-risk women. So once we flag the high-risk women, we make recommendations to the clinician on the fly based on the patient's risk profile. And we generate letters for tracking and compliance. We can generate patient-facing letters for both low and high-risk patients. We can generate letters to the referring physician as to whether a patient is at elevated risk. And the system can even automatically generate pre-authorization letters of medical necessity that we can send out to our referring physicians. They can cut and paste them onto their own letterhead, send them off to Blue Cross Blue Shield to get pre-authorization for those recommended imaging studies. Our goal is to make getting those studies authorized as easy as possible for the imaging center and for their referring physicians. The goal of all of this is for women to have the screening and prevention they need to prevent needless cancer deaths. I'm going to hop out of my slide deck right now and show you a working version of my tool. So, for starters, let's pretend that the patient walks into my imaging center, says they're here today for their mammogram, and my front desk staff takes a look at a list of all of my patients who are coming in for a mammo today. And Adriana is here for her mammo. We select her from a list of patients that we pulled over via interface. Typically that's via a flat file or ADT SIU inbound scheduling dump. We ask the patient to confirm that this is her. Her name is Adriana, her date of birth, and her medical record number. She could switch to Spanish, Portuguese, French on the fly. We have additional languages in the works, but Adriana prefers English. And we have a little blurb talking about why performing a cancer risk assessment is important. By helping us understand your family history and other risk factors, we can help identify if you or your family might benefit from additional screening. And also, if you don't know the answer to any particular question, please feel free to skip ahead. Inherent in what we do is the understanding that when you're asking a patient to provide family history and other information, they may not always remember all of it. And when doing a risk assessment in a screening environment, good enough is good enough. The models all have wired into them defaults for unanswered questions, and it's perfectly acceptable for a patient not to answer any particular question. My imaginary patient is 5'5", weighs 180 pounds, and likes a glass of wine after work every day. We're intentionally making this a high-risk patient. She's a smoker. The age of her first period was 12 years old, and she's still having periods. These are all relevant to hormonal risk. She's never been pregnant. And one key piece, so in a screening environment, the goal is always to get the risk assessment completed as quickly as possible. Often our clients are high-throughput mammography centers, and they don't have all day for a patient to do a risk assessment. Many of these questions have branching logic behind them. Typically, a low-risk patient can be done with a risk assessment in 4 or 5 minutes. A high-risk patient, because there's going to be branching logic, they're going to be forced to answer more questions given their risk profile. This is the first example of a branching logic question. If the patient says yes to biopsy, we have a secondary question. How many biopsies have you had historically? 1. And then this question gets a little bit into medical technology that not all patients may know. 5, 6 years ago, we likely wouldn't have even asked this question. but increasingly some subset of the population getting mammograms is pretty well informed about their health and would remember if they had a specific diagnosis. If the patient knows that they had a diagnosis of atypical hyperplasia, we certainly want to document that. If they're not sure, that's also fine. I'll say no to atypia, and similarly with LCIS, I'll say no to that as well. We're going to say the patient is currently taking birth control, is Caucasian, and not of Hispanic descent. You may be aware that women of indigenous South American descent are at reduced risk of breast cancer. Now, Spanish Hispanic, we're essentially extrapolating the likelihood of them being of indigenous South American descent based on the answer to the question. Likewise, for someone who's of Jewish descent, the real key is of Ashkenazi Jewish descent, but in a screening environment, we're just going to ask if they're Jewish. Have you ever had cancer? So this is the patient themselves. I'm going to get a little crafty here and say that the patient had a history of lymphoma. And she was diagnosed at age 28. I'm triggering a secondary question here as well. Did you receive chest radiation treatment for that lymphoma? I answered yes. And folks in the audience will likely be aware of the fact that just by answering yes to that question, I triggered an American Cancer Society recommendation that this patient get a breast MRI just based on the fact that they had chest radiation therapy under the age of 30. Blood relatives with cancer, so this is the real nuts and bolts of the risk assessment. Yes, we have relatives with a family history of cancer. My sister had a history of ovarian cancer. And this is an interesting piece. This is obviously relevant to breast ovarian cancer, but helps us tease apart the difference between some of the risk models. She was diagnosed at age 38. And now we're going to go to the mother's side of the family. This grandmother had a history of breast cancer. Not in both breasts. She was diagnosed at age 38. And this also teases apart the difference between the models. So you know, the traditional Gale model, which has been around for nearly 30 years, was one of the very early models. And for its day, it was a groundbreaking piece of research to correlate certain risk factors with likelihood of cancer. But as the models have grown and advanced, it's become clear what the limitations of the Gale model are. To the Gale model, a grandmother with cancer, it doesn't affect the risk scoring at all. Now, obviously, you have a grandmother or two grandmothers and an aunt with a history of breast cancer. There's a fairly good likelihood that there's a BRCA mutation floating around in that family, even if no first-degree relatives, moms or sisters, had breast cancer, or heaven forbid, you know, the woman only has male relatives who are alive. So we have no indication from first-degree relatives. But a grandmother with breast cancer is clearly a risk factor. The most up-to-date models, specifically Tyrer-Cuzick, take into account second-degree relatives as well. On the father's side, we have a grandmother and grandfather with a history of cancer. This grandmother also had breast cancer, not in both breasts, and she was diagnosed at the young age of 36. Last but not least, we're going to be documenting the grandfather's cancer history. And one other key piece, in order to reduce the likelihood of patients making errors, all of the cancers associated with a particular family member are gender specific. We can't give grandpa ovarian cancer. Ovarian is no longer an option for a male relative, but prostate is, heaven forbid. We'll give the grandfather a history of prostate cancer at age 55. Last question, if the patient has had genetic testing in the past and is aware of their BRCA status, we certainly would want to know that, but this particular patient has never had genetic testing. So we've now completed my risk assessment, and really, in the end, this is where things get interesting. So we did screening, we asked the patient's questions. Now my risk engine is calculating risk for that patient, and the first thing I'd take a look at here excuse me, I'm just pulling up a particular document. Looking for my smoking document here. There we go. Excuse me. I meant to have that at the top of my list, but I didn't. So, hold on. Let me get back to where I was. So, for starters, we have a patient that indicated they're a smoker. Now, it's a no-brainer to give that patient smoking cessation literature as they leave my center. And guess what? If a staff person, clinician meets with them for a minute or two to discuss smoking, share some local resources where they might go for help quitting, you can actually bill for that. And you can build a good CPT code for quitting smoking because you're evaluating them for cancer and you're doing an intervention for smoking cessation. Even more interestingly, though, are the documents that I generated automatically. The most important document for internal use is my risk assessment summary. We always lead with the recommendations based on that patient's risk profile. So this patient had an elevated risk of mutation. We're potentially recommending genetic testing. We have our primary MRI recommendation based on the fact that the patient has a greater than 20% lifetime risk of breast cancer according to one of the accepted models. And we have the secondary MRI recommendation based on the fact that they had chest wall radiation under the age of 30. Now, one piece that our radiologist clients will often ask us to do is push a copy of this risk assessment as a PDF in a DICOM wrapper into their packs. So it completely integrated into their workflow. They're going to glance at these recommendations, know they have a high-risk patient. They're already thinking about the referring physician who may be getting that MRI recommendation. And you know what? They might even spend a couple of extra minutes interpreting that mammogram, given that we have an elevated risk patient. It's just nice to know, prior to looking at that image, that we have a high-risk patient here. As I scroll down, we see all of the family history and risk factors that we captured from that patient. And we see scores on all of the models. So we see mutation risk, 5-year and lifetime breast cancer risk, 5-year and lifetime ovarian cancer risk, to all the models, BRCA Pro, Tyrer-Cuzick version 6, Tyrer-Cuzick version 7, Klaus, Gale, and Myriad. Furthermore, folks often will ask, what about density-adjusted risk? What about new versions of Tyrer-Cuzick? The Tyrer-Cuzick team has actually chosen our tool for a big validation study. They just received a grant notification from the National Health Service in the United Kingdom to do a large validation study of their previously published density-adjusted risk model. They will be using CRA Health's risk tool to both collect patient information and run the new version of the model for them. So coming soon to a radiology center near you, to a women's imaging center near you, will be density-adjusted risk as soon as that final validation study is completed. We also did colorectal risk assessment on this patient, and it really depends whether that's appropriate in an imaging setting. Some of our clients like to run these models because it's possible to run them given the overlap between the risk factors for colorectal risk and breast ovarian risk. Other clients of ours say, we're a mammography center. We're really not prepared to deal with colorectal risk. We'd rather not have that on our report or even part of our system, and that's also possible. As we scroll down a little bit more, we also see that we created a preliminary pedigree for that patient. Now, if there were a genetic counselor or a nurse navigator in the room, she'd say that's a pretty basic pedigree, but it's a good first glimpse, and we can always flesh that out later if we want to pull that patient into our risk clinic. I'm scrolling up to the top of the report here and capturing that medical record number because I'm going to use it again in a second. I'm also going to pull up some of the other letters that I generated automatically. We generated a lay letter to the patient discussing the fact that they're elevated risk and should probably talk to their PCP. We don't mention any risk scores or anything along those lines. We want to keep it simple for the patient. But then we also create a PCP letter with quite a bit more information. Same information. We have an elevated risk patient here. Here are her risk factors. And because the referring physicians are likely knowledgeable about the risk scores, we cited the 2 relevant risk scores that were greater than 20% for this particular patient. As I mentioned earlier, we also automatically on the fly created a custom tailored letter of medical necessity that we can send on over to that referring physician as well and address to Blue Cross Blue Shield of California requesting pre-authorization for the guideline-recommended breast MRI study for that patient, and typically the referring physicians will cut and paste this onto their own letterhead and send it out to the patient's insurance company. Our goal is to automate the process of screening, decision support, and then getting appropriate testing for those patients based on their risk profiles. So I've done screening, I've made specific recommendations based on the patient's risk profile, and last but not least, I'm going to come full circle and take a look at my clinician dashboard. If we were in a hospital setting or a cancer setting where there was a risk clinic available to refer that patient to, we could take this patient and pull them into our risk clinic. Here we see that preliminary pedigree that I mentioned earlier, and for the risk and genetics folks in the crowd, if I wanted to, I could flesh that out pretty easily by adding some additional unaffected relatives. The patient has 2 sisters, 2 brothers, a daughter, and 2 sons. She has 3 aunts on mom's side and 2 aunts and an uncle on dad's side. I just made that a much more respectable looking pedigree according to a genetic counselor, and I could delve in quite a bit more detail. Let's say one of these aunts, after the patient was done, the patient mentions, oh gosh, I forgot to mention one of those aunts actually had a history of breast cancer. I could add that at the pedigree level. She was diagnosed at age 44. And that now populates back to the database, and I could rerun my risk scores on the fly. One rather interesting piece, and in fact I will rerun those risk scores based on the additional affected and unaffected relatives that I added, just because it's nice to see the patient's risk scores over their projected lifetime as they age. We can look at a model by model basis. The BRCA Pro model has a rather nice piece. The black line is the patient's predicted lifetime risk of breast cancer having never received genetic testing. The green line is the patient's predicted risk if they receive genetic testing and test negative for breast cancer. And the red line is their predicted risk if they receive genetic testing and test positive. And all of that is generated automatically. We're also looking at the Gale model, both versions of Tyrer-Cuzick and Klaus over the predicted age of the patient. Last but not least, I'm going back to my clinician dashboard here. This is where we really manage the practice, and this is really most relevant to the support staff, the technicians, and whoever's actually managing the practice. Most radiologists don't necessarily interact with the dashboard so often. It's more for their team. Here we have a list of all of the patients that we pulled into the system via your scheduling interface. We're tracking in real time all of my patients who have been identified as having an elevated lifetime risk of breast cancer and received an MRI recommendation. In fact, if I click on the pink ribbon, we'll see a list of all those patients who are flagged as high risk, the last time they were in my center for a risk assessment or mammogram, and the last time they had a recommended breast MRI. All of that is generated automatically based on the patient's screening. Any given patient I could take from there and pull into my risk clinic for a deeper dive and a more in-depth workup. But that's a pretty good run through my system. You saw the patient interface where the patients can record their family history and risk factors. You saw risk scoring and decision support recommendations developed automatically based on the patient's risk profile, and then you saw the system's ability to track, document, and follow up to make sure that none of those high-risk patients that we've identified slip through the cracks. It's a very powerful tool for taking what can be a rather complex process and integrating it completely into an imaging center or hospital imaging department's workflow. Thank you so much for your time.